Okay, good morning. My name is Neus. I work at the Hospital de Bellvitge, where for the last 2.5 years, so it's a pleasure to welcome you on this course, and thanks for carrying over, especially to Jara, who's very efficient help to organize this third workshop, and now it's getting bigger. So my topic today is plaque preparation prior to DCB, and as Darius already mentioned, it's a key step in when using this therapy, and we will see a bit how to do this. So as you see in all the consensus documents, optimal lesion preparation plays a central role, and I would say that most of the time and most of the energy and the attention has to be on plaque preparation. If plaque preparation is optimal, then the rest, most of the job is done. So we will, in different consensus, there are different recommendations. We will go through all the steps just to let you see that in the previous document was the first consensus document, and this is the Japanese one, where you see again, after choosing a suitable case, optimal preparation is key. We will discuss how, and then we have to assess and apply the DCB. And this is a third document, more recent. This is from the Asia Pacific Consensus Group. Again, first steps, optimal lesion preparation. So these are my basic recommendations how to prepare the plaque. Usually we start with a balloon that is sized 0.8 or 1 to this reference. Of course, if this balloon doesn't cross, we use a smaller balloon, but we have to end with a balloon which a diameter that is very similar to our distal reference. Why to our distal reference? Because if we have a tapered vessel and we use a larger balloon, we could dissect, we have a bad dissection, and then there's no possibility to apply DCB. So the aim when we apply predilatation, this is a very basic step, but sometimes it's missed by some operators, that the aim is to have a full balloon expansion in two orthogonal views. When we have eccentric disease, it's very important, especially if we're not using intracorneal imaging, to check in two orthogonal views that we have good balloon expansion. If we do not have a full balloon expansion with a regular balloon, we should escalate to another type of balloon, non-cochlear balloon or specialty balloons. We will see that there's a revival of cutting balloons and scoring balloons in this area where we are tending to try to leave less metal on the patients. So we should go slowly, we should predilate slowly and increase pressure slowly. Then increase slowly our balloon size, especially in tapered vessels. Of course, we might need more than one balloon if the predilatation with the first balloon is not enough, or we have a tapered vessel. And this fourth recommendation comes from engineers that they say this is, and I do believe, because in our experience this is how it works, that it's better to use a larger balloon at nominal pressure than using a higher pressure close to RBP with smaller balloons, because it causes less vessel trauma. So this goes together with the recommendation that we should end our predilatation with a balloon that has a similar size to our vessel. And again, consider scoring or cutting balloons. We will see the impact of these devices in the efficacy of the DCB therapy. And remember that the role of the DCB is delivering the drug. So all the job is done before we use the DCB. The plaque has to be perfectly prepared, and then we use the DCB, and we will check how to do this just to deliver the drug. So never goes, let's say, directly with the DCB. That was done previously, and actually in the papers, in the trials that did not insist on good plaque preparation, the therapy failed. Of course, if we have, as we mentioned, ectasias or size discrepancy or aneurysms, we would need more than one balloon. In osteal lesions that are a bit more fibrotic and elastic, consider I would say from the beginning to use scoring and cutting balloons. In stent stenosis, the guidelines support the use of intracoronary imaging to check the mechanism of stent stenosis, and again, if there is fibrotic tissue or calcified nephrosclerosis, we should try to use scoring, cutting, or even IVL for preparation of our tissue before we apply DCB. And we can use all types of devices to prepare the plaque, just as if we were going to implant a stent, or even more thorough, I would say. So we can use scoring balloons, non-compliant balloons, very high pressure balloons, so OPN, IVL, atherectomy, any type of device before we apply DCB. So using, let's say, an aggressive therapy against calcified disease or resistant lesions does not preclude using a DCB. And always, if it was difficult, it took some time to prepare the plaque, take time, wait for, we'd say, 5 to 10 minutes to make sure that there is no plaque recoil before you implant your DCB. So some other tips and tricks. If we use long balloons in long lesions, of course, it's easier to see where the points, the places, the location of the in our long lesion, where there is some resistance, and then we can use special balloons in these locations. It's usual recommendation to do prolonged inflations. That means more than 30 seconds, and this is quite different when we are going to implant a stent where we don't need to do it that long. There is less plaque recoil, there is lower risk of dissection if we go slowly and we increase slowly the pressure. And also, and this is a very practical tip, long inflations, they do some ischemic preconditioning. So when we have to apply the DCB, and usually we apply it with an inflation of about 60 seconds, the patient does tolerate better this prolonged DCB inflation if we have prepared the plaque with prolonged inflations. The use of intracoronary imaging is the topic of Manel's talk, so I will not insist on that, but I think that we all agree that in complex settings, in complex lesions, it is advisable at least to guide our plaque preparation to use intracoronary imaging. So what is the impact of good plaque preparation on patient outcomes? So this is a old trial, but I think that the conclusions are still valid. That was cases of in-stent stenosis, which is the indication where we all started using this technique. So they checked the outcomes at 3 years follow-up, and they checked the angios if adequate predilatation was achieved or not, and they described adequate predilatation with actually the criteria that are still valid, which is presence of TIMI3 flow, less than 30% residual stenosis, and no major dissection, no flow limiting dissection. And they check and it is quite clear that at follow-up, the outcome, the TLR at follow-up, is decreased if we have achieved good plaque preparation following this criteria. So this is for in-stent stenosis, and this is a more recent paper where we also see the impact of the predilatation, the technique, on TLR at follow-up. So you see here that they checked 3 criteria. If we had achieved less than 20% or more than 30% residual stenosis after lesion preparation in in-stent stenosis. They also checked the DEB size according to the stent size. So if the DEB to stent ratio was more than 91%, we had much less TLR at follow-up, and the inflation time of the DCB or DEB. And if all these 3 criteria were achieved or not, and this impact a lot the TLR at follow-up, as you see on the next slide. If we had these 3 criteria were achieved, so we have less than 20% residual stenosis after plaque preparation, DEB to stent ratio more than 1.91, and DEB inflation for more than 60 seconds, you see that the TLF at follow-up is below 10%. If we had partial, so not the three criteria were achieved. We had 19%, whereas if there was no optimization at all, so we didn't achieve any of these three criteria, look, you're almost sure that the technology, that therapy will fail. And you see here the importance of calibration in a very, let's say, a simple case. This is an old gentleman. He had previous PCI on the LAD. There's a long stent, 3.538 proximally, and a 3.523 distally, and also stents on the circ. And he comes for an non-STEMI, and you can see here that we have a focal stenosis on the more distal stent, which is 3.523. So we decided to predilate at high pressure with a non-compliant balloon sized 1:1 with the stent as a current recommendation. And you see after this prolonged predilatation that we have almost no effect on plaque preparation. So we decided that of course this is not a good result, so it's not reasonable to apply a DCB at this stage. So what would you do if you don't achieve good predilatation after a non-compliant balloon? Some imaging, okay. Cutting balloon, okay. So we didn't do imaging because we were lazy that day, but we did use a cutting balloon. And what we usually do is that we tend to undersize a bit the cutting balloon, and we use it at high pressure at some experienced operators recommend. And there's also a publication, the COPS study, where they show that it was safe and effective to undersize the cutting balloon, but going high pressure. Nominal pressure is 6 atmospheres, but there's a wide experience going nominal pressure is 6, RBP is 12, but many operators we do go up to 18, 20, and it is safe. And look, so we undersized. This was a 3.5 stent with stenosis that we predilated with a 3.5 non-compliant balloon. Now this is a 3.0. So this is a smaller cutting balloon than the NC balloon. And look what we achieved after 2 inflations with a cutting balloon. I would say that this is, we don't even see whether restenosis was. So at this stage, so you see the difference after 3.5 non-compliant balloon and after the cutting balloon, that there's almost no residual stenosis. We waited for a few minutes, and then we applied a 3.5 DEB with a good result. You see the final result without wire, a few and 2 different views. And we were satisfied. That was performed 1 year ago, and the patient hasn't come back. So what about de novo lesions? Because we are quite convinced that this therapy works for instant restenosis. So what about de novo lesions? This is a small trial but with long follow-up, where they did DCB treatment for de novo lesions, and they checked the criteria, and this was with IVO's guidance, the criteria that were related to TLF at follow-up. So that the factors that were related to TLF at follow-up were severe calcification, CTO, and plaque area more than 58% after plaque preparation. So they checked with IVO's the plaque burden that was left after plaque preparation. So, and you see that this has a large impact on outcomes at follow-up. So if we left a plaque area of less than 58%, the patients had, let's say, 5 times less events at follow-up than the patients where the plaque burden after plaque preparation and before DCB implantation was more than 58%. So this is this is not the residual stenosis by angio, but we do have some data supporting that measuring residual plaque burden with IVOS can also help to make some decisions. And this is a more recent paper on also guidance with intracoronary imaging. In this case, it's OCT. You probably know these papers because it has become quite popular. And here they performed DCB therapy with OCT guidance, and they checked the factors that were related with TLF at follow-up, and you can see, sorry, I go back, they checked that hemodialysis was related to TLF at follow-up, the maximum calcium arc as well. These things we know, it's the same for DES, that hemodialysis is bad and calcification is always bad. And interestingly, and this is the most interesting finding of this paper, is that the absence of medial dissection on OCT was related to TLF. So it meant that dissections are good, especially if there is the media. Of course, it's not easy, and I'm not saying that we should do OCT and check that there has been medial dissection. But we should not be too scared to see dissection that is reaching the media, as long as we do have a no contrast hang-up and TIMI3 flow. It seems to be related to good outcomes. And here you see the combination of medial dissection and presence of or absence of calcium arc or more than less than 180. So what happens with dissections, as we said, so some dissections can be left, some dissections have to be treated with a DES. So this is a very old classification, but it's the only one we have. And this comes from the area where there were no stents. So the tape A and B can be left alone, as long as we can have a double two drugs. We can see two drugs on the angio, but as long as there's TIMI3 flow and no contrast staining, it can be left. I would put here an orange because some operators do leave type C, some operators do fenestrate. I don't know, maybe we can share our opinion on that. But we should, I think that if you're starting with this technique, it's better to stent the type C dissections, and from D to F, if there is contrast staining, of course, of spiral dissection of no flow, it's obvious that we should stent these dissections. And we do have some data supporting these recommendations. This is an Asian paper from Korea where more than 200 patients with de novo lesions after DCB PCI. So they checked the dissection just at the end of the procedure, and they did angio follow-up. And you see that many of the dissections, so there were more than 30% dissection, 33% dissections during the procedure. Most of them were not present at follow-up. And the presence of dissection did not impact patient outcomes. Okay. So that was mentioned, but there is as well, how can we also assess if the result has been good or not? Some people are using FFR, it's appearing in the consensus documents. The evidence is not that solid, I would say, but some operators are doing it. Antonio Colombo is using a lot the pressure wire to achieve the acute result and to decide if the plaque preparation was enough or not. This is an old paper using FFR, and it's same to use FFR a cutoff of 0.25. One of the things which is not clear is that if we should use the same cutoff value for FFR or for non-hyperemic indexes as when we're using stents, or use another cutoff. It's not too clear. And you know that Antonio Colombo's group is using PDPA to follow the result. They use the FFR to do, the FFR wire, the pressure wire, to do the procedure, and they check again and again if they are above 0.29. The PDPA is 0.90 or more, they accept the result, and the flow is good and there's no recoil. They do a DCB or hybrid strategy. If they do not achieve a PDPA more than 0.90, they prepare more the plaque or they stent the lesions. And using this strategy with a quite high presence of rate of dissections, they end up using only 10% of this and 12% of hybrid strategy. And they had no cases of acute vessel closure. Virtual FFR and other types of MUFR, whatever, are also being used by some groups, and there are some trials trying to show if the non-invasive FFR or imaging FFR are useful for guiding our procedures. And let's say a case where we about plaque preparation in a patient that was done in a live case in a course. This is a middle-old male. He has some risk factors, and he has a stable angina, good LV function, and good renal function. And he has multivessel disease. So you see that there's a CTO of codominant RCA, and the LAD has a tight lesion here involving a large septal and not that large but long diagonal branch, and there's also a lesion on the first diagonal, which is a large vessel. So you can see that the iostoma of the first diagonal is quite tight, and there's a second lesion here involving the septal and the second diagonal. The right had a difficult takeoff, and it's not a long vessel, so we decided to go for, let's say, we try to treat the left system with DCB. So we did imaging of this lesion on the mid RCA LAD, and you see it's a calcified lesion. You see more calcium than you could say by the angio. So of course, we needed to prepare this properly. We went first with a semi-compliant balloon. There is some waste on the semi-compliant balloon, so we went high pressure with a 3.0 cutting balloon. The vessel size was about 3.5. Still not that satisfied. We insisted a bit more with a 1.1 non-compliant balloon, which opened well, but this is the result after plaque preparation. Let's say that angiographically we have more than 30% stenosis, and we checked, since we had the IVUS probe ready, that we did have some fractures on the calcified plaque, but residual plaque burden was above 60%, residual stenosis was more than 30%, and together with all the attendees of the course, we decided to stent this lesion, which is no big deal. Stents, we know that they work. It's a focal lesion. A 3.5 on the LAD has excellent results at follow-up. So I don't think it's a mistake to stent this lesion. I think that we could not prepare the plaque much better than this. And then we still try to treat the first diagonal with a DCB, and we did prepare it with the same semi-compliant balloon, and then we had some, let's say we were quite satisfied. We saw some dissection type, maybe type B, and we ended up with a 2.75 DEB, and this is a final result that was enough. We accepted the result, and the patient that was done 1 year ago, and the patient has been asymptomatic. The RCA was left for medical therapy because it was a small vessel. So final step is to deploy our DCB. So we need the drug to contact the vessel. So the balloon to radiatory ratio should be around 1. We should use a longer, this is different than when we use a stent. We try to size as short as possible to cover the lesion. In this case, we are much more generous. Usually we add 2 millimeters proximally and distally of length compared to the segment we have prepared. The drug needs 45 or 60 seconds to reach the vessel wall, and of course when we have opened our balloon, we should try to deploy it within the 2 or 3 minutes. And remember that these balloons are special balloons. They do not have the same deliverability are some very low profile semi-compliant balloons, so we might need to get extensions catheters, so do have them ready on the shelf, not to lose too much time to deliver our DB. And this is my final checklist for what's an appropriate angio result before we apply our DCB. The presence of TIMI3 flow is more relevant than having or not having a dissection. Wait for 5 minutes in order to catch acute recoil, and we will go through this on the live cases. Do long cine runs to check contrast hang-up. Sometimes we do this too fast and we do not realize that contrast is hanging up there. You can do a cine a few seconds later to check if it's washing or not, and do always through orthogonal projections to assess residual stenosis and to have a proper visualization of dissection. I think it's a safety recommendation as well to do a funnel angio without guide wire, because sometimes the guide wire can hold a dissection and we end up having let's say a more severe dissection when we have retrieved our wire. Again, this is another document. This is a summary of all the recommendations we have seen. Some come from randomized trials, but a lot of recommendations still come from experienced operators, because there isn't that much evidence with the technical recommendations. And if we do have acceptable lesion preparation, as we have mentioned, visual estimation or QCA, less than 30, less than maybe up to 40%, non-flow limiting dissections. The use of imaging will be discussed. With the use of physiology is still a bit not very solid, I would say, and try to implant your DCB with long inflation and a short delivery time as 2 or 3 minutes. And of course, bailout DES is not a failure. It's a part of the strategy. So as a summary, remember that take time to prepare your plaque carefully. Make sure that you have an optimal result before you open your DCB. If we do not have an optimal preparation, use special balloons, and we have a lot of tools to achieve good plaque preparation. Scoring and cutting balloons, they facilitate plaque disruption, and they may enhance the penetration of the drug within the vessel wall. This is why they are used quite often nowadays in the DCB strategies. Remember that dissections occur quite often, more than 50% of cases sometimes, especially if you take some time to prepare your plaque. But most of them, they do heal at follow-up, and they do not need to be stented. And of course, no flow limited dissections, they occur relatively frequent, and we know that they are associated with a good course that was shown in this follow-up angio, where most of them are healed at follow-up. And this is it. Thank you very much.